We now have this wonderful opportunity to ask questions of any of our panelists. So who's the brave soul that wants to go first?
So I recognize there's been a lot of changes and getting advance directives in writing. My question is, if a person has like a well-informed medical power of attorney, but she doesn't want to talk about end of life, you know. I don't want to mention names, but she gave birth to me, okay? That's my question, isn't it? It's not 93 years old, okay? Anyways, she won't go into discussions about end of life, and she wants to be a full code, okay? History of heart and stroke. And then she'll say on the side to my sister, who's her medical power of attorney, she fills out the most form, you know, to resuscitate. So she says to my sister on the side, Lisa, you can make these choices for me when the time comes, but it's in writing on the most form that she wants to be a full code. Can that be entered in something where, like under Part B, where the patient signs that my daughter can make these decisions for me when the time comes? Or does that, yes, CPR, lock in that? Let's say in 6 months she no longer has capacity to make this choice again. So that's my question. And it's in regard to many situations, but I'm just using that as an example.
I can start that one because we get that quite often in the emergency department. And this is, unfortunately, if someone is of sound mind and make the decisions, that's who we're going to talk to. And the reality of it is that someone of that maturity, survivability of CPR and all that sort of stuff is slim to none. And hopefully that can be discussed in the process. But when it comes down to it, if they're of sound mind, they can make that decision. I think that's where the conversation is so important with family members and everybody, because end of life is, everybody handles that differently. And having that support of the family is the key to getting there. So
even if they're not in sound mind when they get to you, that the document, because they were in sound mind when they participated in preparing it, that sticks, the document.
Like Dr. Mills said, it is a document, but there's also the reality of the situation.
Okay.
Which it's different for all of us, but the situation at hand, and I'll speak bluntly, I apologize, but when you have someone of that maturity that goes into cardiac arrest or stops breathing, there are realistic expectations that need to be presented. And so from our standpoint, I would hope that we would do the best that we could, but we're not going to do stuff that I call it futile sort of interventions. But the form is a guide. I like how Angela said that. It's a guide, but every situation is different. So we understand that could be the wishes, and there's also the medical reality. Okay. Not to speak bluntly, but.
Sorry. Go ahead.
I'll just add that to try to give you a concrete answer, if the patient was down, no pulse, not breathing, and he arrived and this was there, he would start CPR.
Correct.
Because it was filled out, it was signed, mm-hmm. and that's his job. They may start CPR in the ER as well, but there's a little more time, and to try to get a hold of the medical durable power of attorney, have more conversations, talk about prognosis, right. Because there's probably a different prognosis at that moment than the prognosis at the moment right. that the person filled this out. And prognosis is so important going into this sheet. Same if the patient was on the floor and they had this filled out with CPR and a code was called, I would probably start CPR and be getting in contact with the medical durable power of attorney as soon as possible. So yes, the sheet is honored. I don't want to take that away from the sheet.
Correct.
But at the same time, I think the bigger thing here is the conversation, which we've all touched upon. And I'll give a very quick personal story. I'm a physician. I've seen many patients, and I've had this conversation with many people. when I had to have it with my own parents, I fell apart. I would highly recommend getting a third party, going to see palliative care, even if you're not at end of life, because palliative care does not mean death, but getting someone who's not in the family and having them lead the family meeting with other members of the family involved, have them just take control. Because there is so much emotion, and then there can be a lot of guilt. That's the other thing I'll say about this sheet is that he or she who holds the medical power of attorney holds a lot of guilt, or at least I have that sense. And I try to say that so many times to that person is, you please remove the guilt. You know, we're at a stage at the end of life where we now have this prognosis where some of these things that are occurring are natural. So I'll just add that.
Thanks. I'm really like your answers. I wish there was a place on the form where it would allow for a medical power of attorney to make the decisions, despite, you know, that it would be in writing that they could make those choices at the end. So I'm glad that you used the leeway.
Yeah, if she didn't have the capacity to make the decision, then they would invoke that power of attorney. So if she had a change in cognition, like she's sick, she's in the hospital, she can't make that decision, the physician doesn't think she has capacity, then that power of attorney is invoked. And so then they are making that call. Yeah, because if she's had a change in medical status, then you really should be readdressing the form anyway, right? So that would get readdressed at that point if she was sick in the hospital. I would say when you're talking with her, or when your sister's talking with her, to ask her why she wants, why full code? Because if she's afraid that we aren't going to treat her, then that we haven't communicated that well to her then as a provider. So I think really asking her the reasoning behind it, and then also asking, like, if she's independent and up in the community, I mean, being a full code might take all of that away from her, and if that's what's important to her, then this might not be the right decision. So I think really focusing on what's important to her and then finding out exactly what the hang-up is there, because it probably is a past experience or something that is preventing her from being able to have that conversation with you guys. It's hard. It's hard.
And I just want to add from a palliative care perspective, I appreciate the focus on having conversations and joining family members in discussing this with your provider. I think you spoke a little bit about medical paternalism and sort of swinging so far the other way, but it's really appropriate, and a tool that we use in palliative care is to get the providers in and sort of talk about, what do you think is the best course for mom, and allowing providers and empowering them to say, I worry that attempts at resuscitation would be more harmful to mom than helpful, or whatever it might be, in a way that mom can understand. But certainly generationally, there are people that hear things better coming more direct from the provider to offer a recommendation. Doesn't take away from autonomy, but hearing a recommendation from your provider can be very helpful.
To add to that, I think there's a huge responsibility for the providers up here and in the community. The worst thing you can do, speaking from an ED standpoint, the worst thing you can do to a family member that's having to deal with this is make them feel like they're making that decision. It is guidance. The medical community should offer guidance to what are the practical outcomes here, to reassure the family that honoring your loved one's wishes is the right thing to do, because there is a tremendous amount of guilt, and that guilt just gets amplified when you're in that moment. A lot of this conversation is outside of the moment. What I deal with is, we're talking about this right now. This is something that's going on that you guys had planned for, that didn't expect, and it's a different perspective. But that's where the can't cuss will hit the fan when it comes to all the family stuff and all that sort of thing.
We said we'd bleep you if you did. Sure. And I'll be the panel plus one, because I wanted to make a comment about that. Because that is, I think, not an uncommon occurrence. And I think one of the points, or one of the things that's driven me to be up here and to be part of this, is because that's somewhat what happened with a family member of my own, and that they had a form that was filled out that said full code, and one of the things of the way that I dealt with it, and there's many ways, and I loved everyone's response, also the idea of getting kind of the phone a friend who can help me have this conversation with my parent or my loved one, but is normalizing it to say, you know, oftentimes people want to pick that because we all want to live, and to help people understand, you know what, we're learning, and we all continue to learn that we oftentimes ask people to make that decision before we've given them the information to make a truly informed decision. And you kind of meet people where they're at, but to say, you know what, can I share with you some other information about this? I'm not trying to force you to change your mind at all, but can we have another conversation about this? And to step back, and with my loved one, it actually did help them understand, because I then talked about, you know, you had told me that you didn't want to be in the ICU ever again, and she's like, no, I don't. And so then I was able to dig in and find that place where there was some space to move things around, and that's one of the important points that I'm glad you brought that up, because I think it's so important to have the conversation so that we don't have people saying yes or no to something and then we're saying, oh, that's not the right answer. We want people to have the information up front. So hopefully that'll help too.
Is DNR ever affected by being an organ donor or anything? I had somebody say to me, I'm not going to be an organ donor because I don't want to be resuscitated, but if you're an organ donor, they might try to keep you alive. So I was just curious about that.
That gets into to answer your question, to become an organ donor, there is, and this is going to get into some ethical things, there is the procurement of organs, which means that you do have to sustain the cell life of those organs. That does not mean that person is alive. So when someone is a DNR, and when you throw organ donation into it, the typical DNR is someone that's had comorbidities, and their chances of organ donation are limited, but it should not affect the ability to donate organs. The catch with that is that you do have to sustain. So I don't want to speak too bluntly about it, but if someone is a DNR and they stop breathing or their heart stops, the time that it takes to start that again to save organs is not realistic. It usually can't happen. And so very rarely, and I don't even know if in my career I've had that situation. I don't know if you guys can speak to that. But it should not affect organ donation. The reality of it is that DNR is your choice on what you want to have done to you, as is organ donation. And they're two separate things. And from a medical side of it, I know that there's it goes into a whole nother panel of discussions on what you could talk about organ donation in and of itself. But in my eyes, and everybody they're two separate things. So I try not to link them together because there's some ethical sort of situations where it brings up some questions, and everybody has different beliefs on that. Not to give you a roundabout and not answer your question, but you guys can stop me anytime, seriously.
I think organ donation is on a continuum, and there are major organ donation options, and then people can be donors of tissue, skin, bones, and provide a gift. And that, as we're looking at end-of-life preferences is something that we talk about. And so really honoring that gift in whatever way that it comes about is important. Some of the issues that we run into in the inpatient palliative care team is in the ICU, when we have patients that are intubated or have a very poor neurologic prognosis, but they're not brain dead, and families are in discussions about quality of life measures and saying, my loved one would never endorse sort of this outcome that we're looking at. They wouldn't want prolonged rehabilitation, or they wouldn't want the picture that's being painted by the team. And sometimes that does come to the case where we get into some ethical situations for something called a DCD process, or donation after cardiac or circulatory death, where timing is part of it. But I'll say that we work very closely with Donor Alliance and do a really good job of supporting families and answering all of their questions as a piece to that decision.
Hi, so I've heard there's some gray areas based on the situation. I'm just curious, what are the legal implications of not following a DNR or a MOS form?
So I'm aware of a couple cases where, from a medical legal standpoint, the providers were sued because a patient wanted to be a DNR and they were resuscitated. Now they're in a nursing home or an advanced care facility with feeding tubes, trachs, and they didn't want that. And they brought on a lawsuit, and they won. And so the reality of it is that the practicality of these sort of things do have implications. Now, the flip side to that is letting someone die, how does medically, legally that look? And so I throw that back on you from my standpoint, because that's what I face. That is what I face, and we face in the emergency department day in and day out. There's a practicality of, well, the form isn't filled out right, or the relative says they want full code, but the form says no code. The family members are coming in, you bring them in, you've started CPR because that's what you're supposed to do. We continue, we don't have the questions answered. And so then the medical legal stuff comes in. I mean, there is this oath that we take, do no harm. And that is part where we go. So we side on this of pushing the envelope of trying to get people back. The medical legal side of it does come into play. And I don't know if Lisa Beth is still here or not, but we've gone back and forth on kind of what should be the default, Should it be life or death? What is and again, something to ponder when you have lunch or something like that. But, but I think that's a very good question, because we side in the medical community and what we do, we side on doing that sort of stuff. And there are legal implications to it. It's a great question.
Well, and the only thing I would also add is having this in the electronic medical record, or whether it's the MOS form or medical durable power of attorney, is so important. And I appreciate the work of some members of this audience, because I know there are some people who are ensuring that this paperwork is in both systems, in the EMR. There were times where I may round on 20 patients, many of which are elderly in their life with severe chronic comorbid conditions, and any type of form of medical durable power of attorney might be found on 2% or less. That's changed. I think this team we're making efforts. But I say that because with your example in the gray, and I agree with everything you said, if I don't have any information, right now I'm going to treat for life. So that's really hard on us as medical providers. If someone had a tucked document in their house at home that said DNR, but that family member got brought to the ER and he started CPR and resuscitated, and now I'm taking care of that patient, we didn't have the information, and we're gonna do our job. So I think it's great that we're having these conversations, and I think getting this work documented in the electronic medical record is so important, so we can use it. That's the end. We're the end users of the information.
And we in the ED, Peggy and I have talked about this before. I mean, it's fairly simplistic for what we're looking for. I think the MOS form is great, and I think it gives, in the end, the best information that you can have on what you want. But all we're looking for is, do you want to be resuscitated? Do you want to be intubated? Because those are the only real things that we can push. And those are the things that, if we see that, I mean, I know we've talked about wristbands and these sort of things, but in the spur of the moment, that's what we're looking for from some sort of guidance on what this incapacitated person wanted. And so that, From the ED standpoint, we like the DNRs checked or not, just because that's right now, I'm not saying it's the best, it's the only tool that we have for a spur-of-the-moment sort of situation to make that decision.
And I would say, just briefly, from the medical legal aspect, I forgot to mention it on the last question. Legally, most forum in the statute, it's written that it can be overridden by a medical durable power of attorney, but the complete intent, and I hesitate to say that because the whole point of this is documenting a person's wishes so they will stand and be their voice, but it's written in there that it can be overridden, but that is not the intent, and that there still could be legal implications of overriding it, but that's how that it's written. CPR directives by fact, which is the form we used to use that I mentioned with the green border, that by law it's not allowable to be overwritten, and so I just wanted to kind of make those clarifications.
And I would like to add a couple of resources for the group. One is on the prior question about organ donation. I don't recall the person's name off the top of my head, but I attended a presentation at the Sharing the Care Network meeting by a woman from the Donor Alliance. And it's important to us on the advanced care planning team, of course, because we help people navigate through those decisions. But she did a wonderful presentation and helped me really understand the difference between tissue donation and organ donation and the way they go about their entire part of this mission in a way that's respectful to families, and they do what's medically possible. So for those of you that are coming here from other organizations, it might be something for you to go back to your organization and say, hey, can we have a guest speaker sometime, and let's have her come in and help us understand this for 20 minutes.
Yeah.
So that's one resource I would offer, and I know that Peggy can connect you or other leaders in the Sharing the Care Network. A resource on the other question about legal implications, and I am not an attorney, and I'm going to paraphrase a couple things that I read, but if you want to go to the LarimerAdvanceCare website and email us, we can get you the detail on this. But we were doing some background reading, and it used to be that the legal principle used to always be life is a benefit. So those folks up there in the old days were always trained, life is a benefit, we are going to help you remain alive, and therefore we're giving you benefit. As Dr. Weideman mentioned, there are a few cases that are the case law is starting to move a little bit toward that allowing somebody to pass on, to die that death and not provide those interventions is considered the benefit in certain circumstances. So again, we have the legal articles that we could send somebody if you're that interested in it, but it is changing a little bit. And what I would say is that's part of why we're all here, is the advanced care planning team, and hopefully you, after you walk out of here as well, will be better at getting rid of the inconsistencies between what the form said and the intent for the POA said. And it's, when we say have the conversation, we mean clarify the values, but we also mean go back and say, now you've told me this, but we've checked this box and I'm not sure that makes sense. Can you help me understand what it is you want? And that will empower everybody in the system to be patient-centered in how we approach this. So as someone mentioned, having a third party be that person, we can do it, the advanced care planning team can do it, but also we're hoping that you'll get better and better at it. And, see yourself with that hat on. Maybe not for your own family, maybe as in your own family you need that other person, but you'll give that gift to a lot of families you work with.
Thanks, Jim. And just from reference standpoint, the gal from Donor Alliance is Catherine Orozco, and she's very happy to come do presentations wherever that's part of her job. So if you want to do that, you can reach out to me and I'll share her email.
I'm not sure how to phrase this question, but so I'm a social worker in hospice, and usually by the time I'm doing the most form with them, they've already decided on comfort care and have a DNR. I would say 90% of the time so far in my experience, or more. But I come into kind of an ethical dilemma often with the medical power of a durable power of attorney and the patient, oftentimes we've got patients who are full-blown Alzheimer's or, some form of dementia. And we talk about decisional capacity, and I'm not quite sure when I'm doing it, where to draw the line with, to include the patient and have them be part of that discussion, even though they're more mentally incapacitated than they were maybe when they assigned the power of attorney, and a lot of times the family wants to protect them by taking the discussion out of the room, and so ethically I'm not quite sure where the line's drawn with allowing them to be part of the conversation and advocating for the patient.
So I run into that situation quite a bit, and I just tend to have the conversation with them there, because I've been amazed what some of my even severely impaired patients have been able to tell me. Just because they have dementia doesn't mean that they can't have capacity in certain realms. And certainly that's one where, like, I've had a husband who's grieving the loss of his wife and wanted her to be a full code, and I had the conversation with her in the room and the whole family present, and she said, I don't think I'd want that. And it made it so much easier for him. So on that chance that they might be able to contribute something of value to the conversation, and I mean, if they don't have that capacity, usually, I mean, you honestly, like, they don't usually listen to the conversation as much anyway. So I just tend to default to have them there, because it's also their care too. I still think that even when you have dementia, you have the right to be a part of your care. And part of that discussion. So it's really hard, and families they just want to, like, protect mom. They don't want to talk about it in front of her, but it's a real thing for everyone, and she's the one, or that person is the one living it, so I tend to have a conversation with them in their room.
And what if it changes? I feel like I've come into situations where, the parents have sort of expressed their wishes when they were still, totally healthy, and then dementia starts to come on and they're like, oh, I want to be saved at all costs, and so it's like, how do you respect those wishes versus the ones they might have said prior?
Yeah, and I had that situation too, and I mean, specifically, it was a daughter who they had that conversation very early in the patient's disease process, and the mom was like, no, absolutely not, do not do these things to me. And then later on, she definitely didn't understand it, and that's when they came to me to have that conversation. And I mean, I asked the patient, and she definitely was like, nope, I want everything done. I want full treatment. And then I just had that frank conversation with the daughter that, she expressed this early on in the disease process. She knew what was going to happen and had a better understanding of it. And I mean, that is kind of where I am more paternalistic about it too, where I'm just like, her reasoning was correct, and maybe she's not able to kind of give you that full answer now, but you had those meaningful conversations before, and I don't disregard that just because something has changed now in her disease process where she can't fully understand what's going on. So it's that capacity thing, which is super hard. But whether you just have to assess whether they have that full meaning of what it really means to be a full code. And usually in that situation, it's pretty easy to kind of grasp whether or not they do. But yeah, it's hard. I just have the conversation with them in the room and just see how it goes. And I just am pretty direct and still have a direct conversation, even if they still say that they want full code. I just say, well, that's probably not the best choice where we're at. And it would be, and really in dementia, if they end up in the hospital, like talk about increased morbidity. It's so hard for those patients if they're in the hospital or in the ER. So I try to steer them away as much as I can, but I totally appreciate your situation.
Thank you.
Yeah.
Hello, this is for Mr. Beckman. You had mentioned something about a new focus on addressing wishes of care, the level of care when your staff is called to, let's say, an assisted living facility. How does your staff assess that whole situation? Do you request access to a most form if it's not available on Epic? How do you do that?
So the first thing we would ask is any of the providers on site if they have a do not resuscitate or a most form. That would be our first object if a case of resuscitation is going to take place. And if they do have one, then we'll review it and honor their wishes. If they don't have one, then we will resuscitate, and then that's when the situation kind of goes from there. Is if they do not have a heartbeat and they're not breathing, and we give them medications to help them help their heart get beating again, and it doesn't work, then we're probably going to leave them there and not transport to the hospital. But what was your question more around lines of?
You had mentioned something in your when you first introduced yourself about having more involvement. Well, that's how I understood it. More involvement to honor. And I know you honor the most in AD form. I understand that part. But how about in the situation of a person where they have a status change and there's no medical staff available at the facility, for assisted living example, and the person still, has a heartbeat. Maybe they fell down or something like that, or some syncopal episode, TIA, something happened. But then their most form says, let's say it's a DNR and comfort-focused treatment. Do you transport those people?
If it's something that we can potentially fix in the hospital, then yes, we're going to transport them. We can do refusals of care, but one of the refusal criteria is that the patient's awake, alert, and oriented and able to make decisions. So if they fall down, hit their head, and they have a head injury, and they can't tell us, no, don't transport me to the hospital, we're going to act in their best interest and transport them.
And so I think we've had a situation for us where your staff have called family and asked about transporting them or not. Mm-hmm. And at majority of times it has worked out fine. They usually have gone, or the person, EMS staff, decided not to transport them. The family did not want them transported. I guess it feels like a gray area, and I want to better understand that as to when we make the decision to send them. And mostly people with dementia, people with cognitive, changes, and that's their baseline. And their most form might say comfort focused, but yet the family member who's a power of attorney cannot be contacted, and you talk to somebody else and they say, keep them here, or even worse, send them and do all these other things. It's just, those decisions made right at the time of having to move a person from where the incident happened to a higher level of care, the ED, and then most of the time those people come right back. And so if we could try to prevent them from even going, ideally, that would be the best.
So, of course, if you don't mind, I can jump in and you can finish.
I was just going to talk about, we work under protocols and standing operating procedures, and it just depends on what the situation is. If a patient fell down, struck their head, and now they're altered, that's one thing. But if someone slipped out of their chair, they have a history of Alzheimer's, we're going to call the power of attorney to maybe not transport, because that patient can't make a decision. So it's very situation dependent as well. Yeah. It's not just a black and white issue, and that's what our providers are trained to do. So. Yeah,
and I was just going to add to that. I mean, you're asking a question that none of us can answer, and that's okay. I think there's common sense that plays in this too. Most forms do not resuscitate, like we said, don't mean don't treat. And to what Ted was saying, every situation is different, and it might take coming to the emergency department to make sure that there's nothing going on, because there could be something we could treat. It might not be the cancer or the Alzheimer's that's causing this change. It could be an infection, or it could be dehydration, and you don't know that until you get them there. And then I understand the frustration of once they're there, they didn't do anything, and send them right back. Well, from the ED standpoint, the way we look at things is we're trying to make sure it's not certain things. And we might not be able to give the answers why, but we can tell you that they're safe to go back. And it's just trying to figure that out. And that's where it's okay to call 911 and have them transport. And we can deal with the personalities of those conversations from an administrative level, knowing how those go sometimes. But no, I think it's not a black and white, and it can get somewhat frustrating and difficult when the power of attorney doesn't answer and you don't know what to do and it's 2 o'clock in the morning and it just is what it is, but that's what we're here for. I mean, you might not have the answers that you want, but that's what we are here for.
I just want to add one more thing. I am so glad to whomever asked that question. I can't see behind the podium, but I truly think this question is the next phase of this work. Just today in the hospital, we have several patients who are in the hospital treated by hospitalists or surgeons who have the most form and were DNR and comfort-focused treatment. And there's a lot of confusion, not only with the providers or, we're kind of like, and we're like, why did the ED, we're always like, what, how?
See,
how,
here we go.
Yeah, here we go.
Here we go.
Right away to the ED. It actually, that's what I said. But there's so much confusion from those taking care of the patient in-house through case management, social worker. Then we're thinking, okay, what happened in the ED? What happened on the EMS side? What's going on at the skilled nursing facility? And we're all kind of pointing fingers at each other. Like, how is this patient here right now? And I really appreciate the answers because each case is different. I agree with if the patient just slipped out of the chair, that's one thing. And so I guess maybe it's our clinical expertise at each place that we have to be practicing at our highest level of clinical knowledge to know when is this something that we could fix or not. And it's hard because someone who's on hospice who broke their wrist, can go get a cast. You don't leave them there in pain. They still have quality of life, and you can treat that. So this is tough, but I so appreciate the question because it's happening right now today. We have patients who are being treated in the hospital that have said they don't want to go back to the hospital, and yet we're bringing them back to the hospital. So what can we do as a community to focus on that area and improve?
And Rose and I share patients that this happens to all the time, and I really do feel like assisted living is kind of that man's land where it's really happening quite a bit for us. And but when I fill out that most form, I really try to reserve comfort-focused treatment just for hospice patients. And I think by doing that, you prevent some of that confusion, frankly. And when they're hospice, the facility feels safer about keeping them there and monitoring them there because they're going to have the hospice nurse and the staff that can provide that extra support. And I think comfort focus is hard because people think, well, of course I want comfort with my medical care, and that should always be a focus of our treatment. Like, you should always have comfort as a focus of your medical treatment, but hospice protects you from the medical machine, right? So if you are really wanting comfort-focused treatment and you want to stay out of the hospital, that's when I really start encouraging families to look at hospice, because that is truly what will keep you out of that place. Otherwise, it really is selective treatment. If you even think remotely that you would want to go back to the hospital for treating something, then we should really be looking at selective. It shouldn't be comfort. Yeah. If you're trying to make it more black and white on the form, at least.
And that's even a deeper conversation, because comfort measures are hard, because the reality of it, when you get to that illness level, the number one cause of certain demise is infections and those sort of things. Well, is treating someone with antibiotics comfort or not comfort, when they have the number one cause that will eventually kill them? So it's a much deeper conversation.
And I would just add one thing to the question about if someone, for example, has selected comfort-focused treatment. One of the trainings that I've had the opportunity to review is giving guidance to folks that are in the community if someone has selected that and they do have an incident that may or may not necessitate them going to the hospital, to have the conversation, again, how important words are, to when you're calling the family, to preface it with, and I'm not saying anyone didn't, but to preface it with, before I called you, I reviewed their most form, and they have selected comfort-focused treatment, which there is a part that says their wish is to not be transferred to the hospital, except if their comfort needs can't be met where they are. And to even hearing yourself say that, I know that then oftentimes that we can help guide families and or medical power of attorneys and staff on if they should send them out. And if you feel like you've kind of used what's in your arsenal and you can't meet their comfort needs, to say our goal is to send them to the hospital, and do their best to communicate that to the emergency department, that our goal is, they're on comfort-focused treatment, but we're not able to meet their need for this. And then the other piece that I know that I learned from experience was oftentimes there would be then a pattern of someone, and we knew they didn't want to go. And so in a care conference or in a conversation, I'd take the opportunity to say, we don't know what the scenario will look like, but what would you like us to do if your dad happens to fall in the middle of the night? And we don't think he's broken anything, but we don't have x-ray vision or CAT scan vision. So that you kind of have an idea, and then to document that, that would be potentially under additional orders to add some of those nuances. And like everyone was saying, every situation is unique and different, but those are some things hopefully that'll be good tools, is to kind of give that little bit of that language. I had a question that I wanted to ask that I feel that maybe each member on the panel, when we leave here today, if we do have a communication issue or we see something happen that we're tending to go oh, they're the emergency department, goes again. Or, wow, I had this robust conversation in primary care, and they go there and the hospitalist seems like they undid things. How do we, each of you, if we do have problems, what's the best way for us to work as a community, in your mind, for us to become a community where instead of pointing fingers and working in our silos, that we reach out and that we work together collaboratively and we ask questions versus sort of they did this and boy am I mad. What are some of the ways that you see we could collaborate?
I would add, and no, it's going to be kind of not the answer that you want, but exactly what we're doing now. Yeah. This is such a, I won't say a paradigm, but this is such a shift to where medicine is going that the community isn't up to speed yet on what we're trying to do, what you're trying to do, and just continuing the communication, getting the education out there. So when they do roll up to the emergency department, here it is, this is what we want, okay, we can honor that. And then I won't have to call Angela, and she won't have to get all fired up and all this sort of stuff. That's.
I agree. I think continued conversations within the community are where it needs to start. I think what we're seeing, or I'll just speak for myself, is we're seeing the culture change. It can feel, in the words of my teammate, very glacial at times, but the fact that all of the individuals are here in the room engaging and learning from each other and reaching out to each other, that would be the other piece that I do in my practice, is if I have a question, I will reach out to the PCP, I will reach out to a team member, and then bring people into those conversations and invest the time in having the providers, the hospitalists, the specialists involved in conversations, whether that be in the hospital setting or in the community. So appreciate everybody's willingness to engage and be here.
I agree. It's about culture change and just reframing how we look at death in this country, and knowing that sometimes doing no harm means that we don't do anything, right? That we know when the appropriate time to do something is and when the appropriate time is to not do something for a patient. So I just think it's great that we have such a diverse group of people here today talking about it. So, because it's going to take everyone. It can't just be one section of medicine. It has to be the entire medical community has to come together.
Yeah, the collaboration and integration with each discipline is important, because someone is going to lay hands on a patient at some time and be able to have that conversation with them. If they're knowledgeable about it, they're going to be able to speak to that particular patient. That patient can take it then to their primary care, and the ball just starts rolling from there. So as long as we're an educated community of providers, and we'll change that culture.
And I would just say, I have a very large assignment for everyone in this room. I wonder how many of us have done this ourselves. Have we filled out a medical durable power of attorney ourselves with our own family, with those who are close to us in our immediate family? And are those records available in an electronic medical record at one hospital system that you know you always go to, or both, because there's a chance for trauma or whatnot? So what I challenge every single one of you in this room, as we're all leaders, is to do this for yourself, do it for your family. There are many people in this room who can help you do it and make it very easy and get it scanned into the EMR. But it's kind of, how are we gonna do this for our whole community if we haven't done it ourselves? And I will tell you that it's the hardest thing to do it for yourself and your family, so if you can confront it, overcome it, get it done, this will be so easy for you, for the community. So go team.
Thank you. Please join me in thanking our panelists.
Thank you, guys.
Now it's time to wrap up, and I wanted to say just a few things about sort of our call to action as we leave this room. Is one of the things we want our community to have is a common language and a common mission and common tools to do this work. And hopefully this is really the beginning of having each of you that do this work go back to your role with a renewed sense of energy and excitement about it, seeing what Dr. Mills, what Angela said about doing it for yourself if you haven't, doing it within your family, because I think that's how we begin to change the culture. And we live in such a unique, not only do we have a beautiful environment, but we have beautiful people. Each of you are the leaders that can help bring this to your workplace, and that's what's going to make the difference is each of you doing it. There's help for you to do it. The Larimer ACP team, the other grantees in our community, you don't have to do this in isolation. How important it is for each of us to support each other, that we know better, we do better when we know better, and so if you know you need more help than today, please feel free to reach out to us, to the health district, to your other teammates that you work with, to say, you know what, this was great, but I need more. And the idea of if we see problems that come up, let's look at them as opportunities to work with each other and work across from community to hospital to palliative care to all the different levels of care across systems, from UC Health to Banner to Associates to Columbine to Sava. That's wonderful. And the importance of if you see that this work needs to be done and started in primary care.
I was just saying that we're just one PCP organization in Northern Colorado, but Associates in Family Medicine does have a social worker now at each of their 8 clinics. So if you're noticing that you have patients that haven't started this conversation and they need a little nudge with their provider, reach out to us. Just ask for the social worker. You don't have to know our names. And we'd be happy to start that conversation on our end and with the doctor as well, because again, these doctors know them, they have for years. Sometimes it's just easier to hear it from their primary physician. So.
A few more things I wanted to share that we've talked about Sharing the Care campaign. It's a group that has an advanced care planning team. If you're feeling something that this is kind of touching your heart, you want to be involved in this effort and this initiative, please feel free to reach out to me. We are working across the community to work to make these not only conversations better, but the relationships that we have with each other better regarding this topic, so there's lots of opportunities to volunteer. I wanted to, do a plug for a project I've been working on for years. I think it's the baby elephant I'm hopefully about to give birth to soon. That is called the Patient Passport. It is it's a communication tool to help patients and their caregivers to navigate in the healthcare system through all the complexity of things we've talked about. And this is a place also why it's meaningful today is because it's a place for people to keep a most form as they're living in the community and carry it with them, and to begin to kind of understand their role in being in charge of their own health care. We have been, the pendulum sort of swings back and forth, but we don't often give caregivers the resources that they need as far as what do I need to manage as a caregiver. And so this is a tool that it also has a book for people to fill out regarding, you know, their current health conditions, medications that they're on, kind of their baseline, so that when they do come in and out of the hospital, that EMS knows some of that baseline information. And so we're hoping to begin piloting this, well, we are going to be piloting it this summer, starting in July or August with the health district's Larimer ACP team. And so also with associates in family medicine, and there's a lot of others that are interested in that. So I wanted to just put in a little bit of a plug for that. But overall, to, you know, why we're here to change the culture in the face of the way our community looks at dying, and to help people understand the importance of having these conversations, not only for themselves but with their patients, to educate people, and then to document those decisions, and then to work towards everyone having better capacity to honor those decisions, because we know that it's been a good conversation, and that it's not one conversation, it's a continuum. So each of us plant seeds that then get hopefully harvested in a meaningful way at the time of need, at the time that person's wishes need to be honored. So unless there's anything anyone else wants to say, I do want to do one more final thank you to Columbine for donating this space, to the Larimer ACP team for donating the food, for the planning team, which involved Mindy Rickard, Jim Becker, the folks from the health district, and Shauna Ostrom from Associates, and Aaron Trabon from Associates, Anna Von Driel from Columbine, I guess myself helped a little bit, and just for each of you for doing what you do. So thank you so much.